So, reviewing neurologic monitoring in infants. So, these are the things that we're looking for. These are also in your textbook. There's box 23.6 on page 549 is a really good kind of overview of all those things that we are looking for when we're doing that neurologic monitoring. But this is the basic overview. We're looking at how they respond to pain, their level of consciousness, how awake and alert they are. We may test their cranial nerves, their motor responses. We're looking for asymmetry there that might tell us we've got increased intracranial pressure. Looking for abnormal posturing, their pupils, any bulging fontanelles, scalp vein distension. If we see their scalp veins bulging out, that's another sign we've got more pressure up there. We've got increased blood flow. Looking for abnormal reflexes there. Those are all going to be part of that neurologic monitoring that we do. So when we do that neuro assessment, we make sure that we're looking at their pupils, we're monitoring their vital signs, looking at that motor activity and their level of consciousness. So that's slide 18 in your PowerPoint this week. And then slide 27 is our seizure slide. So these seizures that are listed here are the ones that you want to remember. So that generalized tonic-clonic, that's that classic seizure that we are all pretty familiar with. We get that aura, that warning sign, then we have those jerking movements, that tonic-clonic seizure, and then afterwards we have that post-ictal phase where we're really sleepy and lethargic. In our absent seizure, that's the daydreaming seizure. So we kind of stare off into space, we kind of check out for a minute, but we never lose consciousness. Partial seizures, again, we stay completely conscious, but those are only affecting one portion of our body. So we might only see it in one arm, one leg, maybe one side of the face. And then atonic seizures, they happen in the morning. So you get jerking when you wake up in the morning and then suddenly you fall to the floor. So those are those atonic seizures. So that's slide 27 in your PowerPoint this week. Okay. Get my textbook out of the way there. Anybody else have anything that they want to add to our laundry list? Okay, guys, we will dive in to our body systems here. So we're going to start with our sensory systems and move kind of in a head to toe fashion over the next several weeks. So this week we're covering sensory, neurologic, and then musculoskeletal. So the first thing we're going to do is look at this scenario, and then we're going to answer a couple questions about it. So just keep this in mind as we're answering these questions. So the first thing we're going to look at is ear infections. They're super, super common in our pediatric patients. So we have parents of a 3-year-old that come into the healthcare provider reporting the child has nasal congestion and a possible ear infection. The provider diagnoses the child with otitis media, a middle ear infection, prescribes amoxicillin, and discusses the possibility of tympanostomy tubes, as this is the 4th time in a year the child has had an ear infection. So with all of those things in mind, what health teaching about those middle ear infections and tympanostomy tubes would be appropriate for this patient? So we recommend tympanostomy tubes in kids that have had 3 episodes of otitis media within 6 months or 4 episodes within the last year, as long as one of those episodes has been in the last 6 months. So these kids typically start to feel better within 24 to 48 hours after starting those antibiotics. But we know that that infection is not completely eradicated until we've completed that entire course of antibiotics. So even though we feel better, we still have to continue antibiotics. Conductive hearing loss is going to be the most common hearing loss that comes with otitis media. So parents need to be aware of that and monitoring for that tympanic membrane acting like that brick wall and not letting the sound through. And then tympanostomy tubes are not permanent. So they get pushed out by the eardrum within 8 to 18 months after placement. And it used to be that if you had ear tubes, you could not put your head underwater. You couldn't get your ears wet ever. But now we know that as soon as that incision is healed, it's okay to get some water in your ear. As much as they provide that ventilation and allowing water in, they also drain that water. So we don't need those special water precautions anymore unless that child has headaches or something when they get their ears wet. So next we're going to look at some eye disorders. We're going to start with our light processing disorders. So typically in normal vision, we receive light through the lens of our eye, and then it gets focused directly on that retina. That's what provides that image for us. What type of sight is it when that light doesn't go all the way back to our retina?
Is it nearsightedness?
Yep. Does anybody know what the medical term for it is?
Myopia?
Yep, that is myopia. So we can't see things far away. What about the opposite? If that light goes past our retina and gets focused back behind it?
Hypoopia?
Hyperopia. Yep. So that means we're farsighted. Everything close up is going to be very, very blurry. So not only do we have light disorders, but we also have movement disorders. So if we look at our picture over on the left-hand side, we've got one eye that is focused straight ahead and one eye that's kind of wandering off. Which condition is that? Yep, that is our lazy eye. What's the medical term? Or what does it start with?
Does it start with an S?
Yes, this is strabismus. Yep. So we've got one eye that can focus directly on the object. The other eye can't focus, can't be directed towards that object. How about our middle picture? So one eye gives you a really fuzzy, blurry picture. One eye gives you a nice, clear picture.
Would that be kind of like astigmatism?
Nope, it's a different A word. This is amblyopia. Yes. Yep. So our brain is going to disable whichever eye is not providing that clear picture for us, so that we can see what we're trying to look at. So that's why you see that one picture is kind of grayed out, your brain shutting off that eye. It's only using the eye that is able to see clearly. How about our last picture on the right-hand side where we've got our eyes wiggling in all different directions?
Is it nystagmus?
Yep, that's nystagmus. So it can happen in any combination of directions, but if you are looking at that person, you will see their iris just kind of fluttering. Um, Is the question how is nystagmus corrected or the other two, amblyopia and strabismus?
The amblyopia.
Okay, so both amblyopia and strabismus are going to be corrected the same way. So because we've got one weak eye and one strong eye, we are going to patch or cover that strong eye, and we are going to force the muscles in the weaker eye to get stronger. So by using that, we're exercising those muscles. We're going to improve our vision by forcing our brain to work with that eye and make those corrections. So always patch the good eye with strabismus and amblyopia so that we can strengthen that weaker eye. So now we're going to kind of deep dive into strabismus a little bit. What are those symptoms that we would expect to see? So if we can't direct both eyes towards an object, then what are some of those symptoms that we would see? Okay, so because we can't direct both eyes towards the same object, sometimes we have difficulty with depth perception. So we might miss something. We might reach too far for it. We might not reach quite far enough. We have a hard time seeing how far it is away from us. We also might try and do the same thing that our brain does with amblyopia. If we can't see out of one eye, we might cover that eye. We might also squint, trying to force them to focus, or tip our head, trying to clear up or help direct that eye. And anytime we have a visual disturbance, it's going to cause dizziness and headaches. So now we're going to look at some of those neurologic issues. We're going to start with that neurologic assessment, those normal and abnormal signs. So we are going to look at Li Mei Wang in our pediatric unit. So I am going to open her in CJ Sim. Okay, let me know if you guys cannot hear her report. We're going to start with report, and I want you to think about what potential neurologic issue she is experiencing here.
Li Mei Wang is an 8-week-old direct admission from the pediatric office being delivered by ambulance. Her mother, Ling, cares for the baby while her husband spends long hours at work. She said that Li Mei has been out of control and won't stop crying despite feeding and changing. Lynn says that 5 hours ago she bounced Li Mei to sleep and then took a nap herself, but she's been unable to rouse Li Mei since.
So based on that handoff report, what do we think has happened to Li Mei?
She had a seizure.
Possibly. What else could it be?
Can it be like shaken baby syndrome?
Yeah. Yep. So high risk here for shaken baby syndrome. What are some of those risk factors that make you think about that?
He was bouncing her,
Yeah.
then went to sleep, and then she didn't wake up.
Yep. What other risk factors does this family have for shaken baby syndrome or red flags?
The
You want-
mom's herself.
Mom's by herself. Yep. Yep. So she's 8 weeks postpartum. So she just recovered from a very extensive hospitalization. She's by herself. Dad works long hours. Um, she has a very cranky baby. Baby is out of control, even though we've tried to meet those needs. So very high risk here for that shaken baby syndrome. So let's take a peek at her chart here. And we're going to start with those normal and abnormal results. So remember, she's a direct admit. So we're waiting for the ambulance. Mom's at the bedside, says her arms were floppy. She was difficult to wake up. She moves with stimulation, but doesn't fully open her eyes. She's not crying. Her chest wall moves. They asked mom about family support. She again said dad works. They don't have any family in the area. Maybe a friend can come meet her in the emergency room. When we do that initial assessment here, we see that Lee May is lethargic, but we can wake her up. She's irritable with intervention, moving those extremities slowly but spontaneously. We've got floppy upper extremities, a little bit of stimulation in the lower extremities. Pupils are equal, reactive, and round, but sluggish. Sclera is noted above the pupils, the right more than the left. Her grip strength is weak but equal, and she has a weak cry. Cardiovascular, we've got S1 and S2 sounds. Lungs are clear, but we have shallow breathing. We've got a distended abdomen, no stool, positive bowel sounds, some occasional vomiting on transport of curdled formula. We're voiding well, no foul smell. We're warm and clammy in places, dry in others. Our anterior frontal is equal to the bony skull. Our cranial sutures are palpable without separation, and we have positive rooting and sucking reflexes. So what of that assessment makes you nervous? What are some of those abnormal neurologic signs that we see?
Pupils sluggish.
Mm-hmm.
Her upper extremities are floppy.
Yep. What other abnormal things do we see in her assessment?
Her pupils are sluggish and her grip strength is weakened.
Mm-hmm.
She has shallow breathing.
Yep.
Her abdomen is slightly distended.
Mm-hmm.
She's warm and clammy.
Yep. Sometimes that can be normal in infants, sometimes abnormal. What are some good signs, reassuring signs that we see in her assessment?
That she's still using the restroom.
Yeah, she's still voiding.
Her pupils are equal and reactive and round.
Mm-hmm. Yeah, they might be sluggish, but at least they're equally sluggish. Same thing with her grip strength, at least it's equal.
Even though like her extremities are slow, she's still moving.
Mm-hmm. Yeah. Still arousable, still moving.
Same with her cry, even though it's a weak cry,
Mm-hmm.
she's still doing it.
Yep, she's still got that pain response.
Her lungs are clear,
Mm-hmm.
no foul smell,
Yep.
warm, no rashes.
All sounds positive.
Mm-hmm. Positive bowel sounds. What do they mean when they say anterior fontanelle equal to bony skull? What is that a fancy way of saying?
That her brain is equal to right? Like,
Yeah, we're talking about that soft spot. So that's a whole lot of words to mean it's flat. Yes, very could have just said anterior fontanelle flat. So that means we don't have any additional swelling causing that increased intracranial pressure. She's not dehydrated. That's a reassuring sign. Same thing with those cranial sutures. We should still be able to palpate them, but we don't want to see a lot of separation because that means we've got swelling that's causing those sutures to separate. And then we still see those reflexes. So rooting and sucking reflex should still be intact at 8 weeks old. So those are good signs. So because we suspect that we have some sort of a head trauma, we are going to take her for some imaging. And we already said that we suspect possible shaken baby syndrome. So we're going to do multiple images here. We're going to do a CT scan of her brain. We're going to do a retinal scan. And then we're going to do a skeletal survey. So anytime there's potential trauma, we're going to do all of those imagings so that we can make sure we're not missing any injuries. So her CT scan shows hyperdensity in the right hemisphere, consistent with a subdural hematoma. So we've got a bleed. We have dilation of our ventricles, consistent with a small collection of cerebrospinal fluid or hydrocephalus. We can tell that the hydrocephalus is acute, not chronic. So it was as a result of this injury, not something that's happened over a long time. The retinal scan shows marked hemorrhaging of the retina with scattered retinal detachment and retinal folds. Thankfully, the skeletal survey shows no other fractures or displacements. So because we have this hydrocephalus, we are going to take Miss Lee May to surgery. Does anybody know what surgery we're going to do?
Give her a shunt.
Yep, we're going to put a shunt in. So we're going to put this little device in that ventricle where they've got that excess fluid, and it's got a tube that drains all the way down to her belly. So that extra fluid goes through that shunt and down into her belly to be reabsorbed by the body. So we're not losing it. So we're going to take her to the OR. While she is in the OR, Child Protective Services and social work are going to meet with mom here. So let's see what they have to say. So obviously, while mom was being transported to the hospital waiting for the ambulance to get there, the nurse from the office had to call Child Protective Services and notify them of the incident. So social work was ready to meet mom in the emergency room. When Child Protective Services met mom, they interviewed her. She denied shaking the infant, stating, "I didn't really shake her. I bounced her up and down on my knee. She seemed to like it. She stopped crying when I did it. Nothing else stopped her crying. You don't know how frustrating this is, and I'm all alone caring for her. I would never hurt my daughter, but I can't stand all that crying." So unfortunately, this is very common, especially when we don't have a lot of support at home. We have a very irritable infant, and we just don't know how to make them stop crying. And we get overwhelmed, and that gets them more overwhelmed. So this is something that we see, unfortunately, a lot in pediatric patients. So what are some things that we can do to help prevent this from happening, even before mom and baby go home from that initial delivery?
isn't it like the same thing when you take a baby home nowadays, they tell you if you ever get aggravated like that, just to lay the baby down in a safe place and go outside and give yourself 10 minutes and then come back.
Yeah, absolutely. A lot of times parents feel guilty about not being able to handle their child, so they don't feel comfortable just laying them down and walking away. So giving them that permission, telling them the best thing you can do for your baby if you're overwhelmed is lay them down in a safe place, take a minute for yourself, walk away, allow yourself to calm down before you go back to your baby. A lot of times they will have self-soothed by then and calmed down. What else can we do?
Talk about a support system.
Mm-hmm. Yeah, so she doesn't have anybody at home that's available to help her. So maybe get her connected with some community resources, maybe some respite care if she needs it, social groups so that she doesn't feel alone. She has somebody to talk to and bounce ideas off of. What else do we need to be watching for with a brand new mom?
Postpartum depression.
Yep, postpartum depression. So we should be screening for that, making sure that that doesn't have a role in this initial incident here. So she's 8 weeks postpartum. So she's still recovering, very new in that recovery phase there. So postpartum depression doesn't always happen right away. It can happen later on in that recovery phase. Okay, guys, great job with her. We'll go ahead and go back to our mentee here. So now we're going to look at some other neurologic issues here. We have a 5-year-old that comes into the ER with high fever, vomiting, and lethargy after a recent viral illness. So which findings would support the diagnosis of Reye's syndrome? So that life-threatening condition characterized by acute encephalopathy and fatty infiltration of the liver, often following that viral illness. What findings support that? Yep, our elevated liver enzymes would match that diagnosis. The other choices that you see there are symptoms of meningitis, so our positive Kernig's or Burdinsky sign, nuchal rigidity and photophobia. Those are all signs of meningitis. When we see focal neurological deficits, it's really fancy terminology here. All it is saying is that there is a problem with the nerves, the spinal cord, or the brain function. It's not an actual test. It's not a diagnosis. It's just saying that we have a problem somewhere in that nervous system. So don't get caught off guard if you see those focal neurological deficits. Here we have a 3-year-old with a suspected case of bacterial meningitis. Which symptoms would we expect to observe? So when we're talking about meningitis, where is that inflammation?
In the meninges.
Mm-hmm. Where are they located?
Your spine.
And
Brain.
yep, brain and spinal cord. So we're talking about inflammation of the meninges around that brain and spinal cord. That's going to cause nuchal rigidity, which just means we have stiffness in our neck. That is that classic symptom of meningitis. So here we have a child diagnosed with viral encephalitis. So what would we expect to assess in this patient? How is encephalitis different from meningitis?
Isn't it just the brain?
Yep, encephalitis is brain only. So when we have viral encephalitis, we've got inflammation of our brain itself. So we're going to see altered mental status, confusion, changes in our level of consciousness. So keep in encephalitis, brain only, straight from meningitis, brain and spinal cord. So our last neurologic issue that we're going to look at is going to be cerebral palsy and also seizures. So we're going to look at Bethlehem, and he is in our pharmacology unit. And we're going to look at his story and how he ended up with cerebral palsy and a seizure disorder. So let's listen to Bethlehem. He is visiting a clinic for treatment of seizure disorders.
Bethlehem is coming as a direct admit from the neurologist's office. Bethlehem has cerebral palsy and a seizure disorder. He was recently adopted 2 months ago, and the family needs lots of teaching. He has a percutaneous gastronomy tube for feedings and medications. The adoption was a private, international adoption, and the health records are very vague. He had a twin who died at birth, and the mother later died of a postpartum hemorrhage. He has been in a private orphanage. He is on phenytoin and some other medications. The adoptive mother and father are with him and are anxious. They say he keeps having about 2 to 3 seizures per day.
Okay. So looking at our report here, starting with, okay, we've got cerebral palsy and we also have a seizure disorder. So we've got 2 different disorders happening. Recent adoption with very vague medical history. What do we think could potentially be the cause of Bethlehem's cerebral palsy?
Maybe a traumatic birth.
Yeah, traumatic birth. So we had a twin that died at birth. Mom died later of a postpartum hemorrhage. So that sounds like a very traumatic delivery. There may have been an abruption or something that caused us to be a prolonged period of time without oxygen during that birthing process. And that could explain both the cerebral palsy and the seizure disorder. How do we feel about his seizure control? Is he well controlled? Is he not?
No.
No, we shouldn't be having multiple seizures a day. So maybe looking at some adjustments to his medications and lots of family teaching. So we've got a brand new adoption here, lots of room for education. So let's take a peek at Mr. Bethlehem. So we'll start with his medical history here. This is what little we know about him. He has cerebral palsy after a traumatic birth, so our assumption was correct there. Also has aspiration pneumonia and that seizure disorder. We don't know of any surgeries other than that gastrostomy tube that is well healed, so it's been in place for a while. Looking at his medications, we can see that he is on multiple seizure medications here. that are not controlling his seizures very well based on that report. So let's look at his assessment here. Get rid of this. So looking at our assessment, we alternate between alert and lethargic. We can make eye contact. We have some irritability with movement and intervention. We are positive for nystagmus. We have grunting for our verbalizations per our parents. Cardiovascular, we've got regular rate and rhythm, S1 and S2. Breath sounds are clear. We do have upper airway and some posterior pharyngeal noises with mucus. So we've got an upper airway congestion. No increased work of breathing, but we are drooling. We have soft, non-tender abdomen, good bowel sounds. We're stooling well, occasionally having diarrhea with feedings. Our G-tube is patent and intact. We're voiding well. We have red beefy gums that bleed with slight touch, and we have a rash all over our trunk. Parents state that rash just started this morning. We also have excoriation around our chin and our neck. Our extremities are spastic. All extremities are spastic. Our upper extremities are going to be contracted in flexion. Those lower extremities are going to be extended and spastic. We are unable to do purposeful or voluntary movement. We are tremoring and restless. Overall, we're well nourished, contracted, varying lethargic and alert states, and not crying. So what are some of those abnormal things that we see with Bethlehem's assessment?
The gum bleeding,
Yeah, what can that be a sign of?
like a bleeding disorder.
What else? Since he has a seizure disorder and he's on medications for seizures.
Oh, a medication, adverse effect.
Yeah, yep. So bleeding gums can be an adverse reaction with phenytoin. What else could lead us to think that we might be having a medication reaction? What else in that skin assessment?
A rash on the trunk.
Yep, we've got a new rash too. So we know rashes and gum bleeding can be signs of medication toxicity. So keep that in the back of your mind for a minute. What else do we see that's abnormal? Grunting may or may not be abnormal for him because he's got cerebral palsy. Sometimes these patients are nonverbal. The contracted extremities, yes, that is going to be abnormal.
Is it noise with the mucus?
Yep, that upper airway noise means he's not handling his secretions well, not able to swallow or cough very well to clear that airway. Likely drooling so much that he's causing that skin breakdown on his chin and his neck.
Don't most patients with cerebral palsy have the contractures?
It depends on what type of CP they have. If they have spastic CP, then they do have a lot of muscle tightness. They have a lot of tension in those muscle groups. So that's when we tend to see those contractures more often because they have a hard time relaxing those muscles. Anything else that we see that's abnormal?
tremoring and restlessness.
Yep. Got tremoring and restlessness. We're going back and forth between being alert and lethargic. We've got nystagmus. Those are all going to be abnormal neurosigns. Unfortunately, not able to do a lot of voluntary or purposeful movement. So that can be a complication of not having well-controlled seizures there. So let's see what else we learn about him. So looking at our assessment of parents, kind of learning how they do everyday life. Adoptive mom says, we were given this measuring teaspoon by the adoption agency. We were told to give him one of these for the phenytoin twice a day and one for the carbamazepine once a day. We mix all the medications in a bowl and put them in a syringe and push them in. Sometimes the feedings and medicines run a little slow. What is wrong with that picture?
Shouldn't be putting all the medications together.
Yeah, we don't want to mix medications. We should be giving them separately. How accurate do you think our measurements are?
Not accurate with all the medications in one tube.
Yeah, we're using a measuring teaspoon. What should we be using to measure seizure medications? Yep. We should definitely be using a syringe, oral syringe, so we can be extremely accurate with our dosing. And then transferring them between multiple vessels is going to lose some of that medication in that transfer. So again, we don't know how much we're really getting into Bethlehem. So we need to do lots of education for this family. So we are going to teach them to properly measure those medications in an oral syringe, how to safely give them via that G-tube route, and also talk to them about seizure precautions. So this education becomes very timely because he starts having a tonic-clonic seizure, so that very general seizure. We turn him on his left side, start him on oxygen, and suction his mouth. That seizure continues for 20 minutes. So we are on the verge of what complication of a seizure disorder? What are we getting very close to? If that seizure lasts much longer, what can happen?
Permanent brain damage.
Mm-hmm. What's the condition where we have a seizure that lasts for 30 minutes or more?
Is it stratus epilepticus or
Yep, status epilepticus. Yep, so that's that prolonged seizure that's not responsive to medication. So we're getting very close to that. So we get our healthcare provider to the bedside and we get a verbal order for IV lorazepam. We are going to teach parents how to deal with this if it happens at home. So at home, we don't have IV medications that we can give. Obviously, we can't give oral medications during a seizure. So we are going to send them home with diazepam rectal gel to prevent going into status. So we're going to teach them how to use it. And then we're going to teach them when to switch to the next higher dose as he gains weight. So we want to make sure that we're titrating based on his weight. So let's take a peek at his labs. What do we see that is alarming?
Phenytoin levels are up.
Yep, our phenytoin levels are really elevated. So that medication toxicity that we talked about, that's why we're seeing that rash and those red, beefy, bleeding gums, is our phenytoin levels are too high. So we are going to switch his medications around. We're going to get rid of that phenytoin because our body isn't metabolizing it well and it's not controlling our seizures. So we're going to get rid of that and the carbamazepine. We're going to switch him to valproic acid and levectrin. So we're going to use those instead. And we keep that IV lorazepam ready while he's in the hospital in case he would go into status. So in addition to that, we also want to get him connected with some therapies so that we can work on some of those complications of seizure disorders that we see. So physical therapy comes and meets with him, measures him for a wheelchair that fits his current size. They also test his spasticity limits and how he's able to engage in purposeful and voluntary movement. And based on those results, they suggest a baclofen pump for him after we get his seizures under control. Why might they have made that suggestion? What would that baclofen pump do for him?
Would it be able to just give it to him as needed?
So this typically will run continuously, kind of like an epidural or an insulin pump. So we would be able to get a continuous infusion of that baclofen. What does that do for our muscles?
It's a muscle relaxant.
Yeah, it's going to help relax those muscles so that we can reduce some of that spasticity, those tremors, that tightness that we're seeing. We might be able to reduce some of those contractures now, might be able to engage in range of motion a little bit better, maybe improve that range of motion. So once we get those seizures under control and we make sure that we're balancing seizure management with minimizing our side effects, then we're going to add on some additional therapies to help alleviate some of those side effects that we can't get rid of. So we want to make sure that we control our seizures first, then we're going to add on those secondary therapies to make sure that we are really maximizing his opportunities for success here. Great job, guys. Oh, before we go away, I want to show you how to submit your CJ Sim report. So once you've answered your questions and you've gone through the medical record and everything, go ahead and finish your attempt. And then submit all and finish. And yes, even though we didn't answer anything. And this is going to be the screenshot that you're going to send me. So you're going to see your initials are going to be up here. Used to be your name, but now it's your initials. The date you completed the assignment, your grade, and your patient's name are all going to be present there on your screenshot. So we have a CJ Sim coming up in week 6. So that's the page that you're going to use to get your screenshot. Okay, so back to our Menti. So thinking about our patients with cerebral palsy, seizure disorders, any type of intellectual disability, how do we optimize their care? How do we support them to allow them to function at an optimal level? You guys can type them in or shout them out, either one. Emotional support, absolutely. They still have feelings just like everybody else. We've got to understand how they function, how they work best, what works well for them. Yep. Learning what's out there, what treatments are available, what resources are out there. Thinking about those basic physiological needs. What do they need to be able to do? Make sure they're fed properly. Yep. So we might have to do a G tube, do tube feedings instead of by mouth. We might have to do some supplements if they can't do solid food. Teaching them to be as independent as they can. Yes, allowing them those opportunities. We can typically do it much faster than they can, but if it's something they can do independently, we need to just be patient and allow that to happen. Yes, family support. Still let them be a kid. Do fun things that are safe. Absolutely. They still need those developmental activities. They might just look different than the peers around them, depending on that developmental age. We've got to figure out how to let them move around. They need a way to move their bodies. They need a way to communicate. Sometimes that's not always verbal communication with them. Lots of technology out there that can be helpful for supporting these kids, allowing them communication, independence. Those are all going to be really helpful for them. Do we have any questions on neurological or sensory disorders? Okay, we will go ahead and move on to musculoskeletal disorders. So we're going to start with fracture identification. So which of these is a green stick fracture? And I am looking at lots of ceilings, so double check your cameras after you've made your selection here.
You said a sprain.
So we're looking for a green stick fracture. So which of those is going to be that green stick fracture? Just click on that picture. So our green stick fracture there, we have a break on one side, the other side of the bone remains intact or maybe a little bit bent, but that break does not go through the bone completely. So that's our green stick fracture. How about an oblique fracture? There are two possible ones on here. Two possible oblique fractures. So these are our oblique fractures. If you think back to geometry, oblique angles, we're talking about a diagonal line here. So that fracture happens at a diagonal across the bone. The one on the left is a non-displaced oblique fracture, meaning the bone stayed in the same location. It's still in alignment. It's just broken. The one on the right is a displaced oblique fracture, meaning the bone moved out of alignment. In addition to that fracture, you don't need to know the difference between those. You just need to know that oblique fracture happens at an angle across the bone. How about our spiral fracture? You guys got it. Our spiral fracture happens from a twisting motion of that bone. So we see a corkscrew-like appearance to that fracture. What is the most common cause of a spiral fracture? What are we concerned for when we see spiral fractures?
Abuse.
Yep, child abuse. So very difficult for a child to be able to do that forceful twisting motion in an injury. So that's why we typically suspect that there was child abuse for that spiral fracture. So when we're treating fractures, a lot of times we will use traction to help put that bone back in alignment. So if we look at our top left picture here, what type of traction is this? Thinking about those three main types of traction. We have one pulley.
Is that the manual?
No.
Is it like a Bucks traction?
Yes, there we go. Bucks traction. So we're using our body as our counterweight. And we're using a weight down at the end of the bed to pull that bone back into alignment there. What are some important things that we need to monitor our patient for when they are in Bucks traction?
Infections.
Yep. What else? When we're doing our equipment checks and doing our safety checks on our patient, what do we want to make sure we've got in place?
The right weights.
Yep, we're using the right weights.
They're not touching the ground.
The weights aren't on the ground, they're freely hanging. What else?
I don't know my fracture, so
What would completely defeat the purpose of traction if our patient was where in bed? If they're using their body weight as a counterbalance or a counterweight, where do we want them to not be?
On our side.
We can't have their feet up against that footboard. We want to make sure, yes, we've got everything in proper alignment, but if they slide all the way down in bed and their feet are resting on that footboard, we don't have any pull on that patient anymore. So we want to make sure that they're pulled up in bed, that their feet aren't on that footboard. Also, really bad example in this picture, but this patient's heels are resting directly on the mattress with traction. So what can that potentially cause?
Pressure wounds.
Yep, we can end up with pressure ulcers. So we want to make sure that those feet are up and lifted off of that mattress, and then making sure that we're not at the foot of the bed. What do we want to do with the head of the bed?
Semifilers?
Yeah, we want to make sure we're not all the way up in high fowlers where we're using gravity to slide us down. So make sure that we're no higher than 15 to 30 degrees for that head of bed. How about our little guy down here with his feet up in the air? What type of traction is that?
is it like a cervical traction?
No. That would be traction on our skull. It's another B one.
Bryant.
Yep, this is Bryant's. So I kind of remember this, that kind of looks like a tipped over Y when you're looking at the bed and the patient and his legs. So that's how I keep that straight with Bryant's and Buck's. So feet are straight up in the air. We're going to use this for hip dislocation or hip dysplasia. So we reserve this for our little patients because we don't want a ton of weight up in the air to try and counterbalance. So we have to be under 20 pounds to be in Bryant's traction. We're also going to need that little safety harness to keep our body in proper alignment so we're not twisting our torso and getting those hips out of alignment again. How about our last one where we've got two pulls here? We've got upward and outward.
That's the Russell.
That's Russell's, yes. So Russell's is all about two different angles of pull. We've got that upward motion where we've got that sling back behind the knee, kind of up under the thigh, providing that lift. And then we've got that extension at the end of the bed. Anytime we're using pulleys, what do we need to check when we're doing our safety checks? What do we not want to see in those pulleys? What would be a bad thing to see in that pulley system?
If they're loose.
Yeah, we wouldn't want to see them loose where that line is slipping out. What else would be a problem if it got stuck in one of those pulleys?
It could cause further complications, like to his foot or the injured foot.
What would happen if we had a knot in one of those lines? If we had, let's say, a knot right here, what could happen?
It wouldn't have better control.
It could get stuck in one of those pulleys and prevent movement. So that would be a bad thing. So we always want to check and make sure we don't have any knots in our lines, make sure that they haven't fallen out of one of those pulleys so that we're not getting the right pull. So all things to check with our patients in traction. One of the complications that we see with a fracture or a patient in traction is compartment syndrome. And if you remember, we looked at compartment syndrome when we did our CJ Sim with Eliza Simmons. So her assessment is over here on the right as a little refresher. What are some of those signs of compartment syndrome that we saw?
Pain.
Pain. Decreased circulation. Yep. What tells us we don't have good circulation here with our patient?
The toes are cool and pale.
We have cool, pale toes.
Weak. Pedal pulse.
Weak pulses. Yep. We've got skin discoloration. Pain, swelling. Pain with movement, especially, we should be able to move without pain. Those are all going to be signs of compartment syndrome. So now we're going to look at some less common musculoskeletal disorders that we need to be able to keep straight. So which of those disorders disrupts blood flow to the head of the femur? So this is our leg calf Perthes disease. So what happens is we don't have enough blood flow going to that top of the femur where it sits in the hip pocket, and that top of the bone starts to die off. So it causes a lot of pain with walking and immobility. So the easy way to remember this, I'm all about those silly remembering tricks, is LCP, lack of circulation problem. So that'll help you remember we've got a disruption to the blood flow at the head of the femur. So which disorder is going to cause progressive muscle weakness? Chastity, I don't know what you are doing, but you are not engaged with class. So you either need to join us or you need to log out. Duchenne's muscular dystrophy, we end up with that progressive muscle weakness. So we see these boys tend to be very clumsy, they fall a lot, they have difficulty with movement, and eventually that progressive muscle weakness will lead to death from either cardiac or respiratory failure. These patients tend to have a really big sway in their back, scoliosis. They tend to have a pot-bellied appearance because of that sway in their back. They also get fat deposits in their calf muscles. So it looks like they have hypertrophied calf muscles or really large calf muscles. So this only affects males. And which is our last one that causes the head of the femur to be displaced in the cup of the hip joint? Yep, that is our slipped femoral capital epiphysis. So that growth plate that is in between the head of the femur and the long bone portion, we have a little slip that happens there. So that femoral head stays up in the hip joint, but it gets a little bit separated from the rest of the femur. So again, it's going to cause some limping, some issues with movement and pain typically. What questions do you guys have about our musculoskeletal disorders? Okay, I will go ahead and get our Kahoot pulled up here. And we
I have a question. I have a quick question.
Yeah.
Is that going to be on our test, the muscle? Is it something we need to focus on?
Yes, musculoskeletal will also be included on our second exam.
Neuro as well?
Yes. Yep, week 4 and 5 are going to be covered on exam number 2. Chastity, this is your last chance or I'm kicking you out of class. Okay, guys, we will go ahead and start our Kahoot here. You can join us later if you need to. So our risk for Reye syndrome, so aspirin administration with some sort of a viral illness that gives us those flu-like symptoms. So that's going to be a diagnosis of varicella. We've got that chickenpox virus. So that diagnosis is going to increase our risk of Reye syndrome if we use aspirin. So this is that green stick fracture again. We've got an incomplete fracture. Only one side of the bone is broken. The other side remains intact or bent. If we have blood in the anterior chamber of the eye, so we're going to see a collection of blood in the front of the eye, that's going to be called hyphema. So if we have a fractured femur, what level of pain is that? Mild, moderate, severe?
Here.
Yep, severe pain. So we're going to go straight to those opioids because that's going to be our medication of choice for that moderate to severe pain. So anytime we have fracture pain, sickle cell pain, trauma, those are all going to be treated automatically with opioids. So we get that adequate pain control. So Brian's traction, the one where their feet are straight up in the air, is going to be reserved for, 30 pounds. So Haemophilus influenza B, our Hib vaccine, protects them from influenza. So when we have a child with hearing impairment, we want to make sure that we're still engaging them. We don't want to disclude them from the conversation. We want to make sure that we're face to face with them, talking in short sentences, so we allow them time to digest that information. Sometimes signs and gestures, especially if they're really big signs, can kind of interfere with their ability to read your lips. So we try not to overly gesture or sign when we're communicating with a patient that has hearing impairment. When we're doing that cranial or neurologic assessment, we're looking at those signs that tell us we have something wrong in our brain. So our lung sounds and our heart sounds have nothing to do with our brain. So we're looking at motor activity, pupil assessment, level of consciousness, and those vital signs. So a child experiences episodes where he appears to be staring off into space. This is that absent seizure. These kids get classified as daydreamers because they seem to be just kind of off in their own little world sometimes. So if you're talking with them, they'll be engaged with you, having a conversation, and then all of a sudden their gaze will be fixed off in one direction. They'll be staring off into space and will not be engaged with you, and then all of a sudden they'll come back. So these are usually really short seizures. They just all of a sudden kind of stare off into space, lose their train of thought, and then they regroup with you. So the cardinal or classic sign of a brain tumor is a headache in the morning. So when you wake up, that increased intracranial pressure can cause projectile vomiting and also seizure activity as well. If we've had an amputation after an osteosarcoma, yet we still report left foot pain, we need to medicate that. That's that phantom limb syndrome. So even though that limb isn't there or that part of the limb isn't there, the nerves still are reporting pain. So it is still very real pain for them. So we want to give them appropriate pain medication. So when we have a child in Bucks traction, we want to make sure they stay pulled up in bed so that we get that counter traction for that weight that we have. We want their heels to be elevated off that bed surface so we're not causing pressure ulcers. If we put the bed in high Fowlers, gravity is going to pull them down to that footboard where we do not want them to be. Anytime we are talking about risk with fractures or traction, or we're talking about minimizing complications, your neurovascular checks are always going to be your answer. So your neurovascular checks save you from complications. They minimize the risk. So that's going to be the way you're going to identify compartment syndrome or anything else going on with that circulation. So a 30-degree curve with scoliosis is going to be that middle of the road defect there. So we're going to use a Milwaukee brace. So that's that hard plastic kind of torso brace that we use. What do we put under the Milwaukee brace to prevent skin breakdown?
Isn't it like a padding?
It's just a t-shirt. Light t-shirt is the only thing that should ever go underneath that brace. Never any lotions, never any powders, just a thin t-shirt. How long do they have to wear that brace? How many hours?
Is it 8 hours?
Is it more than 15?
23.
I
So they
wasn't going to say
be
that.
in, yes, they need to be in that brace other than when they're taking a shower. So the whole purpose is we've got to maintain that alignment in our spine and strengthen those muscles around it so that we can hold that posture ourselves. So we need 23 hours a day to keep that alignment instead of just falling in and out of that alignment. So with hydrocephalus, we've got that extra fluid in our head. We've got that giant boggy head that's really soft. How do we keep these kids safe before we can surgically correct this? Yep. So we're going to monitor our vital signs and our neurologic status so that we know anything internal that might be going wrong. And then these kids need to be turned frequently to prevent skin breakdown. So if we've got all that fluid and that soft tissue around the skull, if we leave them in the same position, then that soft tissue is going to start to break down, just like a pressure ulcer. So we want to make sure we're turning these kids frequently to prevent that skin breakdown. Also monitoring for those potential complications, so vital signs and neurologic status. And they would actually do better with their head of bed elevated so that gravity can help that flow of cerebrospinal fluid to go back down out of their head. If we are experiencing a seizure, we want to make sure that we get everything out of that child's immediate area so that they aren't causing injury by hitting something. We never, ever, ever put anything in their mouth or manually restrain them. We can cause more injury doing that. And we don't want to leave this child because they're not able to keep themselves safe. So send somebody else for help. So our atonic seizure is the one where we have jerking movements when we wake up and then we fall to the floor. Good job. So Milwaukee brace, the only thing that ever goes underneath it is a t-shirt. It's got to be on 23 hours a day, especially with our adolescent patients. This can be really disruptive to their body image. So we can use looser clothing over top of that Milwaukee brace to help disguise it. But the only thing that can ever go underneath is just a thin t-shirt. The most effective pain management plan is that scheduled medication. So that low dose analgesic, something like acetaminophen, scheduled around the clock so we get baseline coverage of pain, and we can add supplemental medication on top of that for any additional breakthrough pain. So our pediatric patients don't like to report pain because they're afraid of an injection. They don't want a shot. So they will deny pain. So we are better suited to just give them scheduled medication around the clock so that we're capturing that pain. Let's get one more in. Great job, guys. Anytime we're on antibiotics, we have to take the entire prescribed course We can't stop as soon as we start feeling better. We know we won't fully eradicate our infection then, and then we become antibiotic resistant. So it looks like Mel is our winner today. Great job, guys. So let's take a peek at what is coming up down the pike for us. So last week was our exam. This week we have our week 5 NCLEX questions that are due and our discussion for post. Next week is our second exam and we have our first CJ Sim that is due. So Reese Diaz is our first CJ Sim. Like I showed you when we were going through our Sims in class today, make sure that your initials, your patient's name, the date you completed the assignment, which has to be done during the week that it was due, and your score, all 4 of those things are going to be visible on your screenshot that you submit for your CJ Sim. With having an exam next week, we do still have some exam reviews that are available. Maybe. So this afternoon at 1 o'clock Eastern time is Professor Luminoso's exam review. So she's our last one for live reviews. As soon as I get Professor Adair's recording, I will add that to our announcements. Same thing with Professor Luminoso's once I get it this afternoon. Also in your announcements are the screenshots for your week 5 NCLEX questions. So remember to ask for an exam, 50 questions. We're choosing our content areas. The rest of our NCLEX questions are always going to be in the pediatric setting. So for week 5, we're doing cardiac, eye, ear, musculoskeletal, neurologic, and throat and respiratory. So that's going to help you as you're studying for your exam because a lot of those conditions are going to be part of the exam. The part that everybody's forgetting is step 4 here. So make sure this new only box is white, meaning it's unchecked, and then reset your used questions. And those 2 steps will guarantee that this number is 50 and you won't have to redo your assignment or submit a low score. Does anybody have questions over anything that is coming up?
Could you restate when the exam was?
Next week. So week 6 is the exam. Our last exam review is this afternoon at 1 p.m. Eastern Standard Time. So you guys have the recordings to date so far. And then you have your exam 2 review PowerPoint, your Kahoots. I did not put math worksheets in here. I will add your math worksheet in here as well. So there'll be a math worksheet for here as well to help you out. And then just using your week 4 and 5 study guides to help you with the content that will be covered on the exam, in addition to that PowerPoint.
Didn't you mention that it's heparin and insulin questions on this?
Yes. So your math questions this time, the next 2 exams, you'll see heparin and insulin questions for those math problems. So if you're in my exam review, I mentioned that our brain automatically thinks that we're asking for a volume over time conversion or formula for those questions, but we're not. That's the only time when those formulas can be a little tricky is with insulin or heparin. So because that dosing is in units per hour for continuous infusions, we're actually asking what dose we need to administer for those questions. So when you see an insulin question or a heparin drip question, those are going to be DHQ questions. So if you use your DHQ formula, you will always get those questions correct when it comes to an exam. What other questions do you guys have?
What type of formula did you say? My computer is going in and out.
So for insulin drip or heparin drip questions, you want to use your DHQ formula.
Okay.
Yep. Anybody else have questions?